society. So through the policies that we pass, through the treatments that we have, and the different services that are available for folks to access. And we really do believe that language matters, that the way that we think about things matters, and so to sometimes challenge our assumptions that we're making about people, both positive and negative, can actually really lead to positive change. So if nothing else, we're here to present a couple of different viewpoints that might make you think or question what you thought you knew, or like us, get to a point where you realize you have many more questions than you do answers. That's the goal.
Yeah, I think basically by the end of this presentation, we will explain what causes addiction and how you treat it. I'm just kidding.
I'm going to go now. I'm just going to go, yeah.
This will be quick, yeah. We were talking before we got here about how it's, by the end of this and all the conversations we always have, we don't have those answers, and it's almost, there's more options than when we first started out talking about it. So, yeah. Mm-hmm.
But some of the questions that we're going to talk about today are what is the biopsychosocial model of addiction? What does it mean when we hear people say that addiction is a brain disease? What does the socio-relational model have to add? And why should we care? What does this all mean for the way that we design our services and our supports? So why are we talking about this right now? We're talking about this because we still have no shared understanding of what addiction is. And when we say addiction, we're meaning not just substance use. There is an evolution of substance use over time that for some folks really does end up resulting in harms and on patterns and problems that are qualitatively different in their nature, and that do respond to treatment. They do respond to supports, and they're also able to be, some of those harms are able to be offset by what we call harm reduction services, and that these are all important parts of what we as a society have come to understand our service system should look like. But even that being true, we still don't have a shared understanding of what exactly that is, a shared definition of what that is. Some people refer to addiction as a chronic relapsing brain disease. Some people refer to it as being a dysfunctional behavioral pattern, a normal response to really severe psychosocial stressors, and a lifestyle choice, which is sort of the flip side of a moral weakness, a moral sort of failing.
I think the biggest thing that I'm going to keep hammering home during this is that it's not a one-size-fits-all model. And that's for basically every aspect of what we're going to talk about when it comes to substance use, including the causes. I know for some people in recovery, brain disease and hearing it's a disease is a helpful thing in early recovery because it takes away some of that blame and shame that you put on yourself that it is a moral failing or a choice, and that can really help. Other people, they don't like that model. It doesn't work for them because they feel like they're cursed with this disease and they're going to have it for life, and they feel sort of helpless, like there's nothing they can do about it. So I think the big thing is that it's different for everyone, and that's okay, right? However people want to view it or look at it.
Absolutely. And I think you've highlighted a really important point there, Evan, which is that if you're responding to the idea of a brain disease in a positive way to make sense of your experiences, doesn't that mean that at some point in the past you were experiencing this condition as being a moral weakness, and that it's helping to, the brain disease explanation is helping to alleviate some of that sense that you had internally that there was something wrong with you in the choices you were making. To some extent, all four of these explanations are present in our current society. And we think about drug policies, so at least for the past century, our drug policies are heavily premised on this idea of lifestyle choice and moral weakness. There's a behavior that is a choice, and people are free to choose it, yet if the choice or the behavior is something that is morally unacceptable to society, then we'll pass a law against it.
I think another hard sell about the disease model is the fact that if we're calling addiction a disease and saying it's medically a disease, it's not treated like any other disease. And that comes down to the way addicts are treated and the stigma and the treatment that's available. The weights you have to go through, the judgment you experience showing up at different places for help. So it's all well and fine to call it a disease, but it's certainly not being treated as such.
Evan, I remember you told me once the couch of willingness.
Mm-hmm. Yes. So there's horror stories, but there's so many different ways of looking at and treating addiction. There's a book out there called The Couch of Willingness that was written by a doctor who ended up going down his own road of addiction, and it's a fascinating book. So he ends up going through treatment centers over on the mainland, and he goes through all the different sort of treatment centers, and has been kicked out of them all because he keeps relapsing. And he finally, the bottom of the barrel, he ends up at this place. I can't remember the name of it, but they have what they call the Couch of Willingness. So you show up there on the doorstep, and there's this couch that's covered in puke and piss and sweat, and you have to basically lie on this couch and detox for 24 hours in order to get into the treatment center. So it's this idea that you put yourself in this position, and we're going to beat you down to nothing in order for you to be built back up, right? Which there's probably some people that works with, maybe a very small percentage. But I think the biggest thing is there has to be all different modes of care options for different people.
But probably maybe a fewer couches of willingness.
Yes. Yes.
So we're going to go through a couple of models, common models, or understandings, so conceptualizations of addiction. And we'll go through what the definition is, and then we'll talk a little bit about what that actually means. If we really believed that this was true, how would we treat people, both formally in our healthcare and criminal justice settings, but also just how would we treat them as human beings? So the biopsychosocial model of addiction is probably the most common and the most well understood at this current stage. It's arguably what most people in the field would identify with. Sometimes you see spiritual added as well as another dimension to this model. And what it actually means is that it's a model of health and illness that acknowledges there are biological, psychological, and social dimensions to the condition. And all of those should be attended to by a clinician, so in treatment. I can think of ways that I've seen this play out in my research, Evan, more around things like services for women should, women who are experiencing problems related to their use of substances should have a connection to child protection services, because the women, to the extent that they are experiencing involvement with the child protection system, are experiencing levels of difficulty and harm and psychological trauma related to that experience, and that if substance use treatment is going to work, it's going to attend to that. So that would be an example of the biopsychosocial model.
I mean, I think all these things that we look at are being treated in some way with drugs or alcohol by the people that are using, right? And so when we take away the substances, when it gets to a point where those aren't working anymore, or we can't keep using them, we take them away, and we're left with all these things that we've never actually cured or dealt with. So yeah, it makes perfect sense that once you remove the substances, we should have treatment that will look at all these different areas.
Which we acknowledge is very difficult to do in practice, and examples of or reasons why are, there's many, but a really good reason is that, you know, in Canada, in most Western countries, we have our departments of government. So our governments are divided into divisions, such as the Ministry of Health, the Ministry of Child and Family Development, the Ministry of, so like the poverty one, I can never remember, social innovation and something like that. It's got an interesting name. Poverty reduction and social innovation? Yeah, thank you. And And it's difficult for those, one has a jurisdiction, a mandate for housing, one has a jurisdiction and a mandate for health. And so, never should they meet. And it's tricky when you've got different funding mandates, different understandings of what a client is, different understandings of the way the problem that you're supposed to be responding to is framed. That's really tricky to try and overcome those barriers. Can be done. It's being done really, lots of interesting solutions. And there are examples out there of it, but we can see why there's barriers to making that work. Brain disease. It's a big one.
Mm-hmm.
It's a brain disease. So the brain disease actually, the brain disease model of addiction started appearing in the late 90s. That was sort of the first time we saw it come to the fore. We've seen it shift and become a primary model of how we understand addiction and problematic substance use. We've seen people react against it. Academics in particular, love to join the camp that they're in and die on that hill of addiction is or is not a brain disease, which I was at a meeting once where somebody else stood up and said, look, do you think dentists sit around arguing about whether a cavity is a disease? Can we maybe at some point get past this and actually try to create a system that's going to help? The brain disease is in effect the biological component of the biopsychosocial spiritual model. So it's a narrower, more restrictive definition or conceptualization of addiction. And its strengths are that it does define the most proximal or the most direct causes of behavior, because those are within the individual, and behavior is linked to your brain, and that should not be a surprise to anyone. What it misses out on are these other important dimensions, and both the psychosocial, the psychological and the social, as well as spiritual. So those patterns of brain activity, the damage that's caused by substances, we're not saying that that doesn't happen. We're saying it's a somewhat incomplete, or sometimes we call this a reductionist view of the phenomenon of addiction, because there's something missing in that it's a very proximal, very deterministic kind of set of risk factors.
We talked about this before, which is, this sort of obsession to find out what causes addiction and where it originates from, and sort of what's behind that and what's the point of it, because it's almost, it does come to this blame thing, right? Okay, we can take away the blame if it's actually a disease, whereas there doesn't need to be any blame put on it anyway. There
doesn't need to be any blame put on it, and I wish that we could come to an understanding that we don't need the brain disease to give us compassion. And in effect, as an individual who is experiencing problems related to their substance use, you can make sense of your experience in a lot of ways, and certainly the brain disease can help you do that. And if so, it's awesome. However, at a population level, there have been some studies that have asked people to fill out surveys, and when we do that, we find that the brain disease actually does not lead to lower stigmatization or higher compassion. People who endorse a brain disease model still heavily stigmatize people. It's led to sort of the perception that folks are out of control, that they can't control their behaviors, that they're dangerous, that coerced treatment should be the norm because people can't make decisions around their need for care, that's the incompetence under the law kind of argument. These are all where, in effect, the brain disease has led us. Now, that's a one-sided viewpoint. I'm going to fully acknowledge that it's also led to some good treatments. And it can, and it will continue to do that. And the more knowledge we have about neurobiological processes that underlie substance use patterns, the better off we're going to be. But let's not sort of oversell the idea that the brain disease is going to solve the problems of the way that folks who experience addiction are treated, because it's not going to.
I love that dentist example. I was just thinking back on that. Someone shows up with a cavity, you don't see the dentist and everyone else there sitting around going, is this because they didn't brush their teeth, because they ate too much sugar, or, you know, were they born with weak teeth because it runs in the family? Or you don't try and figure out all the causes of it, you just treat it.
That's right.
Which is what we need to be doing with addiction.
Exactly. I want to talk a little bit, you just said weak teeth. Let's talk a little bit about genetics, which I love this aspect of addiction. This is like fascinating to me. So we know that this runs in families.
Mm-hmm.
Yeah. We know neurobiologists, neuroscientists have isolated somewhere upwards of 1,800 different genetic combinations that predispose people to problems related to their substances. This is not up for discussion. We know there are genetic components to addiction, but what does that mean?
Again, I think it's back to it not being one size fits all, right? I'm an alcoholic. Neither one of my parents are alcoholics. I have alcoholism in my family if I go back a couple generations, but it's not so cut and dry that, okay, your parents are alcoholics, you're going to be alcoholic. I've seen people that were raised in homes with alcoholic parents, they don't become alcoholics. I've seen people raised in homes with alcoholic parents and they turn to drug addiction. And then we look at that and say, is that because it runs in the family? They got that addict gene? Or is it maybe because of some of the trauma they experienced growing up in an alcoholic home? There's just I think basically there's every possible example and combination you could think of out there, right? Which makes it impossible to pin down. Yeah.
And I think, so that raises, in the scientific world, we call that a multi-deterministic model or multifinality, equifinality. These are principles where you can get to the same endpoint in many different ways, and those pathways themselves lead to many different endpoints. And that's what we see with addiction. So what about genetics? Genetics is one risk factor among many. And just because you have a genetic predisposition doesn't mean that you're for sure going to develop the health condition. And just because you do not have a genetic predisposition does not mean you're immune. In the case of substance use disorders and addictions, is really interesting because there's that environmental component, right? If you don't have the drug, you can't show the genetic predisposition. So that is the most, the clearest, most extreme way of conveying that a genetic predisposition is not deterministic. So let's say you grew up in a society that didn't have access to alcohol for whatever reason. Really wouldn't matter if you had a genetic predisposition. You're not going to develop an alcohol use disorder. And that's why what we actually see in reality is moved way beyond this nature versus nurture kind of argument to say there's actually a lot of intersections between those two. Those factors interact with one another. An early childhood trauma may trigger a genetic predisposition. That predisposition might turn it on, and the reverse might be true. So you may carry a genetic predisposition that never gets turned on.
And I think there's so many theories that people feel so strongly about that aren't the answer for everyone. That like every single person with addiction has experienced childhood trauma. That's simply not true, right? And then how do you gauge that? Trauma can be completely different things for two people that have been through the exact same experience. One can be traumatized, one can just shake it off kind of deal, right? And I think that with all these factors, it again seems to come back to getting to the blame issue a little bit, right? Okay, it was the parents' fault because they've got addiction issues, or you know, they didn't nurture the kids enough, or whatever it may be, when again it's just not one size fits all.
Exactly. So really, these genetic risk factors that we're talking about for, you know, your parents having a condition, your grandparents, that can affect your own likelihood as a person of being exposed to an environmental risk factor, which you could then respond to. In the same way, your genetics also determine to some extent the way you shape the environment around you. So your genetic predisposition might be towards particular ways that you're constructing your environment around you, which increase or decrease the likelihood of encountering a problem with your substance use. This is a very, very close tie, and it's why we see all these different patterns of outcomes among people who do and do not have genetic predispositions. But certainly someone who has experienced addiction problems to say, you know, I don't want to have kids because I don't want to pass this on. It's not the way it works. And I had this, so I caused this in my kids, is also not the way it works.
So I think it's frustrating for people not being able to have that answer and put their finger on and make it a one-size-fits-all thing. It causes frustration because it's harder to treat that way when you don't have a one-size-fits-all model.
It certainly is. If we espouse this idea that addiction is a genetic disorder, what does that mean for treatment?
The conference is now in lecture mode.
What would that tell you to do?
Right? Brain surgery? Like remove that part of your brain? Like there's not, I think there's just, and again, it's not the same for two different people. It's the same thing, right? And you look at a brother and sister raised in the exact same environment with the exact same parents. One's an alcoholic, one can drink responsibly. How do you explain that?
Yep.
That's a genetic thing.
Right. There's clearly something else.
Yes.
That is a factor that's important. And that brings us to the social relational model. Addiction is a disorder that is rooted in socio-relational processes with important neurobiological, psychological, and behavioral manifestations, super fancy definition. And what it really means is that human beings are inherently social creatures. And even if we think about, this model was actually put forth in response to this idea of people falling into camps of brain disease versus choice moral weakness, and that we've got a continuum, and people are vying for their, you know, where they fall along this continuum and what they think treatment and services should look like. And so these two scientists put forth this idea that what if addiction is actually fundamentally social relational in that it describes a relationship that you have to a particular behavior, which is related to the use of a drug, and it's your relationship to that behavior, what it means in terms of the reward that you experience, the pleasure that you experience when you take the drug, the effects that it's having on you, and that social relationship, the totality of the social relationships and experiences that you've had in your life that are leading that to create that relationship, which then shows up, is manifested in what's happening in your brain, what's happening in your psychology, and in your social relationships, which I think is a very interesting way of showing it. It's a very interesting description of what addiction is because it's rooted in those social causes. It can explain, this model can explain why people have different relationships with substances across a large population that's stratified into these different levels of being marginalized, stigmatized, people who are struggling with poverty, people who are racialized or have been treated very poorly by the Canadian government, that their relationship to substances is different, and the way that it's playing out in their lives is different because of the different access that people have to resources, to social justice in their lives. So it's able to kind of capture that aspect of social justice and structural determinants of health at the same time that it's acknowledging that, of course, the most proximal determinant in any given behavior is going to be brain-based. If we really believed that this was true, how would we structure treatment?
I think when it comes to the social relations too, it's a tricky one because in my case and a lot of other people's cases, substance use starts out as such a social thing and it provides social connection. I mean, for me, it was easier to fit in with people, to have those difficult conversations, got rid of the anxiety and depression, and it absolutely was a social thing in the beginning. By the end, I was completely isolated and on my own, and that's so common. I've heard that story a million times, right? But in our brain, we're still convincing ourselves that this is a social drug. This is what helped me make friends. This is what helped me socialize with people, and this is what I need to be able to do that going forward. When it's turned on you and you haven't really realized it because you're completely alone and isolated, which is why we often see in treatment, a lot of the treatment options do have that social connection,
Right.
Whether it's meetings or groups or treatment or recovery houses. Such a huge part of it is connecting with other people going through the same thing and basically learning how to socialize and how to make friends without having substances present.
Right, because you need to have that.
Absolutely.
You need to have that component.
Yeah. And it's hard, and that's really a tough sell in early recovery because a lot of us have been isolated for so long with our substances that, to be told that, okay, you have to go from, maybe interacting with one person at the liquor store for a month to all of a sudden sitting in a room with 30 people and talking about your feelings. And never mind that, you're going to do that without any alcohol or drugs to help you get through it. It's a freaking hard sell in the beginning.
That would be a hard sell for me.
Uh-huh.
Yes.
But it's what we need and what we crave at that point, right? Which is why I remember going to treatment, and it was absolutely terrifying going to be with a bunch of people I didn't know and didn't know what to do, but it was such comfort and relief to be surrounded by people that understood what I was going through.
To me, this also points to the importance of harm reduction services, and so I've heard many times harm reduction referred to as love, as connection, as helping people to connect with one another and find that sense of belonging. And I mean, we can say that, that's flaky or that doesn't seem like it's enough, like it's a pretty poor response to a terrible problem, and fair enough. But at the same time, if we think about addiction and socio-relational concepts, that's huge. That's important. It would explain why we see positive outcomes resulting from engagement in the system. It would suggest that we shouldn't lose the opportunity to engage someone in the system regardless of what it is that they want.
Totally, and I think people, have the right to that human connection and that support and help, whether they're using drugs or wanting to stop using drugs, and that can change too. It can go both ways, and we've seen that. I mean, but an example of the harm reduction connection I always think of is a former sponsor of mine who was on the downtown east side using, and he couldn't keep up with his addiction, couldn't keep it going, so he ended up going to the methadone clinic to get prescribed methadone. And that was like, he was completely alone and isolated out there, and he started to make connection there. And even in that 10 minutes, he had to go get his methadone. He was talking to someone. He was talking to a worker, a counselor, whatever it may be. And eventually, there's some trust built, and that those conversations got longer, and they talked about what was going on, and it led to him ended up going to detox and getting help. So it can be such a huge opening point, right?
And if at any point along that way you stepped in and said, well, that's not really what this service does, or that's not really what we want for you, or that's not really what you should want. You should want this instead.
Right.
I mean, is that really where we want to be? Is that really how we want to be responding when, especially in a particular context that we're in now with a poison drug supply, and those opportunities for engagement are even more important because they could be a matter of life and death.
Absolutely.
So we've gone over these in different ways over the course of our conversation. What do these different models of addiction mean for treatment? Off the top, they mean individualized interventions, which is what you said a lot, that we need to tailor our services to what individuals need. I'm not going to tell you how to do that. I don't know. I just get to highlight the problems. But there is evidence
Yeah.
that a treatment system that has the capacity to deliver tailored continuum of services, that is a, we'd say a gold standard or a fundamental or core principle of good treatment design, good treatment system design.
And I think we're starting to see some progress in that area of recognizing individualized interventions. It's tough because so many treatment centers or places you go for help have already their set idea of what success is, right? For them, that's you leaving the place and never using drugs or alcohol again. Well, that's not everyone's goal going in, and that's not always success for people. And you know, there's going to be stops and starts. And as some people, if they're using once or twice a year, that is a freaking massive success for them.
Sure.
Right? And we're keeping them safe and supported to be able to do that. And we may see that change over time too. So I think we're starting to see a bit more of flexibility around realizing different people need different things and have different paths and have different ways to measure success as well.
And I would say that my experience as a researcher entering a lot of treatment spaces over the past 20 years, I'd say different treatment spaces have different rules and different set goals. And it's up to the person to find the one that matches what they want.
Totally.
It's not up to the treatment center to say, you've landed on my doorstep, this is what we've got for you.
And often
that's tricky.
Often they don't find that out until they're in there.
Yeah.
And they've committed and given up their housing and packed up and essentially moved to this place.
Right.
And then they realize 2 days in, okay, this is the path I have to go down. This is not something that works for me or that I'm willing to buy into. So I think that's where it's important to have multiple different options and places and people like Umbrella. So keep a little plug there, but you know, people that know what the different treatment centers are and what they offer, and we can really explain it to the client and make sure that that's the path they're wanting to go down. So there's not a huge surprise when they get in the door.
The myth of incompetence, the idea that people can't consent to their care because they meet the legal criteria for being incapacitated or incompetent. That, to me, is very dangerous. It's not a universal experience by any stretch of the imagination, and the research is absolutely clear on that. And it's also clear that techniques of coercion, whether that's a choice to go to treatment or jail, a choice to go to treatment or lose your kids, or whatever it is, choice, they manifest in very complex ways. There is no sort of single, simple understanding for what that does to people. However, it is certainly going to shape their experiences over time with the system in ways that we might really want to question whether or not that's something we want to go down at a population level. When we also consider the way that social injustices connect with addiction, and we embrace the social relational model and the idea that there is a social underlying root cause that's driving the behavior that we're seeing in a given moment, again, I think we want to be really careful the way that we are creating and making policies that are going to potentially further isolate people, that might potentially bring them in to a system in a way that does not allow them to determine their individual fit. And certainly, some people might end up getting mandated to a treatment that does work for them and might be very grateful for that. And nothing of this precludes that from happening. However, if we think about a big system and the way that we want to structure it, are there other options that are available to us to support people? Why are we excluding harm reduction pathways to an improved quality of life, whether that involves substance use or not? Why are we excluding those off the top? Because we kind of feel like maybe there's a better way. What would we call that? A moral weakness manifestation, right?
I think the game has changed with this one a little bit in recent years. I mean, we were sort of getting to a point where we realized we can't force people into treatment. It's not going to work. They need to want the help. We need to let them hit rock bottom before they can get well. But we've had fentanyl show up on the scene and sort of blow that wide open, right? Which is now we have a level of desperation that we've never before seen.
Absolutely.
And we have people showing up to the hospital with overdose after overdose after overdose. And desperate family members wanting kids to be forced into treatment so they don't die. It makes sense. We can understand why. But all of a sudden it's like, okay, everything we believe now is being put into question. Because if we can't afford to let this person hit rock bottom because they're going to die before they get there.
Yeah.
And so how does that change things? It's difficult because it still doesn't change the fact that this isn't going to work if we drag this kid into treatment and force him to be there for 2 months because he doesn't want to be. But at the same time, is he going to make it?
And maybe what the problem is there is the treatment fit and the service that's available and is acceptable to the person.
Mm-hmm. Yeah, it's a tricky one.
The role of medications is also a really tricky one because we've learned a lot, certainly, from having a deeper understanding of the neurological basis of substance use behaviors. That does actually help in the discovery of medications. And, if we can alleviate some of the suffering and the discomfort that people are feeling as they're negotiating their own path of recovery, we should do that, I think. I don't think that medications need to necessarily be viewed in a negative light or as a panacea, because that's also not going to be the case for everybody. And I guess I worry a little bit, or I've thought about this, but I haven't done anything about it. It's pretty par for the course, actually. I'm very busy. I thought about this, like, what if somebody who uses opioids right now and is at high risk of overdosing, what if they don't want Suboxone or methadone, and they go to detox, and detox says, what? If you don't agree to go on Suboxone now, we're not going to take you.
Reason being, and you can understand both sides of it. Reason being that if someone is, has a high tolerance and is using, and they go to detox cold turkey, and 7 days is pretty tough to stay sober with after, and there's a giant gap in the system, so they're waiting to get into treatment. They have to wait to get into stabilization, whatever it may be. They don't have the tools to stay sober. They're going to go out and use. They have no tolerance. They're going to overdose and die.
Yeah.
I get it. But at the same time, it's like, are we forcing people onto this medication if they want to get well?
And sometimes that's going to work. And sometimes it's going to go south. And I am, as not a clinician, what I am good at is conceptualizing the problem frame. So what's the problem frame with someone saying, I would prefer a different route of service? The problem isn't that they would prefer that. The problem is that the system isn't set up to be able to find it for them in a way that's actually arguably going to be ideal. And so we're at a stage where frontline service providers are needing to make that kind of decision about whether or not they're going to help someone who's asking for help based on these system shortcomings. And it's been like that for many, many years. That's not new now. We're just seeing it in a different way now that's making us question whether or not we're on the right track, which I think is a good thing, that we're questioning and thinking about where we need to go from here. But I would say that the crisis right now has really, really starkly shown how ill-prepared the system was to be able to handle this kind of problem.
And I think the answer is more and more of everything, right? I mean, it would be ideal if we had somewhere people could go to get off opiates, and they don't want to go on Suboxone or methadone, that's fine, but we got somewhere they can stay for a month, right? With no wait time to get in, and we can support them during that time and slowly work towards that. And
safe supply.
Absolutely. Or and we still have the option for people who want to get on Suboxone or methadone as well.
Absolutely. And people can change from day to day, too. Oh, that's all you had to do? Totally. Well, that's easy.
Totally.
Okay.
That's fantasy land.
If you have any really serious disagreements with anything we've said, you should email Evan.
So my email address is karen.urbanoski.
No, that's not fair. And I would like to open it up for some questions and discussion. You can sock it to us.
We'll just, and Karen and Evan, I'll ask you to, if we get any questions from the floor, to repeat them for the people listening online so they can hear them too. And I'm just going to get out of the maximize here so you can see any of the questions on the screen. There you go. There's been some chatting going on while you've been talking.
Yes, yeah. Definitely need to broaden the discussion to address stimulant use. Yeah, and I mean, we could talk all day about stimulant use. We could talk all day about alcohol use. We could talk all day about opiates, and there's so many different substances and areas that need attention and care. I mean, stimulant use it's challenging to treat right now. There's not a ton available.
So we have a question, Evan. What has your experience been with people who use meth or crystal meth heavily in contrast to opioids? You would be the correct person as the service provider to answer that.
Well, I think the difference, a big difference, is the treatment available, right? When we have someone who's been heavily using crystal meth and they come in wanting to get help and wanting to get off it, and they're often in psychosis, we run into this challenge of, okay, this is a mental health issue, not a drug issue, because this person's clearly in psychosis. We can't help them at the substance use level. Okay, let's send them over to psych. Oh no, we're not touching them. It's, they're doing that every day. This is a substance use level or substance use issue. And so then this person's cast adrift in psychosis with a full-blown addiction. And we're trying to find some way to help them. The other piece too is when they come in, often there's not medication they're given that can help, right? I think of one guy that went into detox who had been using crystal meth heavily, and he was just sitting there on the couch, right? You could tell his brain's on fire, and he's looking around. It's like he just needs to be knocked out at this point and to sleep, right?
Yeah.
I mean, I'm not claiming to be a doctor and thinking I can do that, but I think the treatment. We're not quite there.
Just to be clear, Umbrella doesn't knock people out when they come to stay at the Foundation House.
Not officially, no.
No.
And just to confuse things, there's fentanyl in all the crystal meth now too. So
right.
we got people coming in that have been using crystal meth heavily, and it's suggested they get on Suboxone, and they're like, what? I've never touched an opiate in my life. So all the worlds collide basically these days.
And I see that we have a comment on the chat window that the Crosstown Clinic in Vancouver has a Dexedrine pilot program, which would be a substitution in the same way that we do opioid substitution, but for stimulants. Absolutely, right? If that is what helps for folks, then these are the kinds of interesting and innovative forms of services that allow us to do better in not losing the opportunity to engage with folks.
I think we missed some from her.
Oh, probably. That was technical.
I know. Yeah, questions from the floor. Please.
Is there an active policy within the treatment model of harm reduction that people have to start on methadone? That doesn't work, and Suboxone, that doesn't work. Because what happened, luckily for my daughter, is she became one of the first people to be given Cadian, lower morphine.
Right.
And that made all the difference to her.
So I'll repeat the question just for the people online. The question for Karen was, is there a policy specifically about people with opiate use challenges that come in? Do they have to start with Suboxone and then go on to methadone, et cetera?
Yes, there is, or has at least historically in the way that that programs work, that has been kind of, and there is sort of still that like first line of medication, and then if that doesn't work, we shift, and so there is an order to it that is that does have. It's not that it doesn't have evidence; it does. But then also treatment choices have evidence of a different kind, but it is still evidence. And somebody who is navigating through the system, they're often in any given clinical encounter, service encounter, they're not coming in fresh. They're coming in with a whole other previous encounters with the system, maybe with respect to that medication they're looking for, maybe not. And those are also shaping the care encounter. And so it's a careful line, I think, for clinicians to walk. It's to figure out how far they're going to push something. And to some extent, I'll just say this, it can be taken as being controversial, but I think some of the reticence to moving to a safe supply, to heroin prescription kinds of models, actually, at least like right away when someone comes into the office and says, this is what I want, some of the reticence to do that is actually vestiges of that idea that those drugs are bad. And we shouldn't go that route until we've gone this other route and we've exhausted all these other things. So as a person who has never and will never be on the clinical side of needing to make that decision, it's very easy for me to sort of say, like, I can question whether the evidence suggests that we should go through these drugs before we arrive at a so-called safer supply kind of approach, that we have to exhaust these other possibilities first. Is that because those other possibilities are better, or simply because we've studied them more, simply because we have some preconceived notion that we should be doing that? Because we've always done it that way, because that's the right way to do it, because these other drugs are more dangerous, and like that's a tricky thing, right? Like, and to some extent, that's not a question that research can answer, because it would be you could never test a study that would test that.
Can we go to Bill?
Bill, yeah.
Just a comment there. The decision about what form of OAP is used is a clinical decision.
Yeah.
And there are some disadvantages to using Canadian, and that's why it's not
right.
It often uses the first time.
Yeah.
There's some practical.
Yeah, and safety profiles of different medications. That's true.
And I had my hand up before because I wanted to put in a plug for another biological treatment, which is a medication for alcohol use disorder, which you didn't mention, and they have a really important role. And I see a lot of the people here are non-medical clinicians, and I just want to encourage people to consider those as one of the things that can help some people. Genetics probably entered into this largely because some people are helped a lot by those medications, and other people not so much.
So thank you, and Bill raised the point that we did touch upon opioid substitution or medications for opioids, talked about medications for stimulants. We didn't also mention medications for alcohol, which aren't substitution medications, but they're medications, and they're vastly underutilized relative to the evidence that is out there that they can be helpful for some folks. Naltrexone, acamprosat, gabapentin.
There's a number of drugs now that can be helpful with craving.
If you have questions about that, you should email Bill.
Yeah, we've got expert addictions doctors in the crowd, so it's a little intimidating trying to answer these questions.
I don't think so.
Aaron Bullock looking at me. Yeah.
I am very confident.
Are you? That's why I directed it to you. So.
Yeah.
Okay.
Mm-hmm.
So this one comment here was something we were talking about before, which was the differences between the definitions of addiction and definitions of substance use disorder. So we literally had a conversation about this before we came in here.
Sure did.
Yeah.
So I'm gonna, I'll start. Not being a researcher or clinician who is rooted in biomedical traditions, I understand my world in different ways, and I understand the research and what's helpful to me in terms of concepts as I'm doing my research and planning my studies and those kinds of things. Substance use disorder is a medical diagnosis, and it's a very specific pattern pattern of symptoms that have been outlined that present and co-present in different ways. And they're very much about the individual behaviors and neurobiological experiences that manifest in the person that help a physician or a psychologist to recognize, okay, I'm listening to the way you're talking, I'm hearing you describe your behavior, I'm seeing this substance use disorder. And it's meant for that. That's what the diagnostic construct is meant for. As a diagnostic label, because it is a stigmatized condition, it can lead to detriments to the person, as well as to benefits in terms of opening up their ability to access a service, and leading to further stigmatization, loss of employment, maybe loss of income assistance. It can have both effects, but it is, in its basis, a sort of a very biomedical understanding of the phenomenon that I find in my own research as a social scientist, and I'm an epidemiologist by training. The diagnostic construct doesn't give me everything I need to be able to understand the phenomenon and to design studies that contribute to what we know about the service system. So I have always preferred the less well-defined, more all-encompassing idea of addiction myself. Now, that is not the same thing as calling someone an addict. That's not person-first language. That's essentially saying someone is the same thing as saying someone is schizophrenic. Someone is, they hold a stigmatized condition. We're not acknowledging they're a person. We're seeing the condition first, which is not something that we should be doing, and we need to do better. If you have lived experience, you get to make sense of that and refer to yourself in whatever ways that allow you to be able to represent that identity. But the rest of us do have a duty to use words that are not stigmatizing, and I am fully aware that not everyone has experienced the term addiction in a positive way, and that's tricky and that's tough. But I think that the problem there underlies kind of the fact that people don't know what it means. They're still equating it with the idea of a moral weakness. And to the extent that that is how people understand that term, then it is something I should move away from.
Yeah, and addict is not a bad word. Like for a lot of people, it's important to identify that way because it reminds us that we can't use substances, and we need to remind ourselves of that every day in order to stay sober. Some people do prefer that label. Other people, it doesn't have any flexibility. And I think the substance use disorder piece, that's the same thing. It doesn't seem very flexible to change, right? And we talked earlier about problematic substance use and how that can change so quickly and go back and forth across the board, right?
And problematic substance use is tricky too, because who defines the problem? Who defines whether it's a problem? How is that something that you get to define yourself? Usually not. Usually it's defined for you in some form of an institution. And so these are all really tricky terms, but it comes down to this idea that this is still a pattern of behaviors and experiences that are really stigmatized in our society. And to some extent, it almost doesn't matter what you end up calling it. Those feelings and those judgments about the morality of the individual who's experiencing them are still going to be there until we actually really think through the way in which our response to people is an example of conceptualizing this, whatever we want to call this is, as a moral weakness as opposed to a socio-relational issue or health condition.
Thank you. Great presentation. I appreciate your time. I just have a comment about the use of substance use disorder and the terminology and the concept of that, and that is that I think that it does have a pretty unique use, and that is that we understand substance use disorder as a spectrum, and that it gives us an opportunity to intervene at an earlier stage than crisis, right? So that the idea that we can do early intervention based on where we can step somebody out. I'm not a clinician, but, and as a professional who's worked for many years in the health policy field myself, I've always kind of been struck, and somebody who's been in recovery from addiction, use both terms, for 30 years. I've always been struck by the lack of resources focused on early intervention. I mean, obviously the people who are dying on the streets deserve the resources now, but there's just such a lack I feel, in the substance addiction treatment community for that, and I just wonder if you have any comments about that lack of attention to early intervention.
I agree 100%. I think there's a lack of everything.
Yeah.
This is what it comes down to.
Which, on a sheer volume basis, if you think about the volume of folks who are affected by these issues, it's pretty disgraceful that the share of funding that goes to supporting people is so small compared to other conditions, and the brain disease has not led to increases in that. People still can't get service. Yeah. Yeah.
I think that's policy advisors towards decriminalization.
So how do we move policymakers, or should we, or should we, how can we, yeah, move policymakers towards decriminalization? Certainly I think we're increasingly coming to realize that the criminal record is not helping people, and it's causing a lot of harm. How do we move policymakers to it? Gee, I wish I knew. If anybody knows, they should speak up.
You got a hand up
I
here.
believe there is some work taking place. I know the Recovery Capital Conference here, the film and some of the work that's going on in downtown East Side and the Portugal model, and trying to have conversations about it in British Columbia. So at least the conversation is
I think I'm getting the
I'm seeing people start to filter
the
out.
hug. Yeah.
We could just keep talking until there's no one left. Yeah, we're on all night. No, that looks like we're gonna wrap it up.
Hi everyone, I'm Todd Aspect. I'm with the practice support team, mental health and substance use practice support team here with Island Health. And we have a saying in our curriculums and the work that we do, and that meaningful conversations don't end, that they just pause. So we're being mindful of the time and the use of the space, and just seeing, well, we're over time by now, so let's pause the conversation, but clearly there's a lot of investment in the conversation here today. So I really want to thank everyone for showing up, being present, everyone online for showing up, being present. Our Island Health Research and Capacity Building team, Caesar, our Island Health Scholar in Residence, Bernie, Polly, you were missed today, but I'm sure you're here in spirit, of course. And our Substance Use and Research Evidence Exchange Community of Practice for making this, everyone for making this happen. But of course, Karen and Evan, I want to thank you so much for being so generous with your time, your voices, and the vulnerability that it takes to come up here, present your work and yourselves and your spirit and your heart that you're carrying in this. This is a big deal. It's very meaningful. We have a recording online that can be accessed if folks from a previous conversation that was very similar. If folks are interested, you can contact mhsu.pst@viha.ca. I'll slow down if someone's actually interested. mhsu.pst@viha.ca. And that'll help connect you to our SharePoint, Community of Practice SharePoint, which has a previous recording that we've been getting a lot of really great feedback about due to the multiplicity of the conversation. That was fast. Thank you so much for your time.
Thank you.